very good afternoon to fellow doctors and also to Dr. Thurkadevi, our speakers today. Today's topic is a very important, at the same time, a very crucial topic to discuss with. This is due to the number of suicide cases linked to mental health has spiked significantly in the country, over about 80% last year compared to the year before, literally. This is actually was mentioned by our former health minister, Khairy Jamaluddin, recently. Mental health is not a tangible disease. Unlike a broken leg or a heart attack, it is something hidden that you cannot see. A study has shown that it is common for a person to have psychotic symptoms for more than a year before receiving treatments. Reducing this duration of untreated psychosis is critical because early treatment often means a better recovery. Without further ado, let me introduce our speaker today. Dr. Thurkadevi Munikanan graduated from Malacca Manipur Medical University and obtained her postgraduate training in psychiatric in University Kebangsaan Malaysia. Dr. Thurka is also a certified mindful gym trainer, provides mindful-based therapy and mindfulness-based cognitive therapy. She joined Taman Desa, Taman Desa Medical Center as a visiting consultant psychiatric in 2021. Apart from practicing in our hospital, she's also a part-time lecturer at Perdana University. Okay, doctors, the floor is yours.
Thank you, Ms. Louis. A very good afternoon to everyone. Thank you for this opportunity by Taman Desa Medical Center, and welcome everyone for this talk for this afternoon, which is based on diagnosis and managing psychosis in primary care. Let me share my screen. Okay, so diagnosing and managing psychosis in primary care can be sometimes even challenging for many of us. Even after long duration of practice, still some time we find very difficult to really pick up the psychotic symptom in the patients that we are seeing day to day. So what is my outline for today is will be what is psychosis, briefly, type of psychotic disorder. I will discuss briefly on schizophrenia, which often missed and take very long to actually diagnose and start the treatment for schizophrenia. And why I want to also discuss on this, because the symptoms can vary from the initial phase, the phase of schizophrenia itself, and then the recovery phase. So I thought it will be very helpful if I discuss on this. And next will be management and monitoring. And I will also discuss the cases that I used to see and get referral from GPs, so that maybe if anyone encounter any cases, such cases, you can refer more earlier than we used to do. Okay, what is psychosis? Psychosis is actually a general term to describe a distorted perception of reality. Okay, it is characterized by delusion, perceptual disturbances. I will just briefly explain on this later. Disorganized thinking and behavior. So the psychosis can be symptoms of schizophrenia, which I'm going to discuss in a while. Mania, part of bipolar symptoms. Sometimes in bipolar patients, when they are in manic phase, they also can present with psychotic symptom. Depression, they can also present with psychosis in later stage of the depressive illness itself. Delirium, which commonly we can see, especially patients with underlying infection, anemia, severe anemia, and end-stage renal failure, kidney dysfunction. All this organic problem can present with delirium, where we can see psychotic symptom, very acute onset of the psychotic symptom In dementia, they can also have psychotic symptom, and substance induced, which is quite commonly we can see in day-to-day life as well. So type of psychotic disorder can be a lot, okay? One of those is schizophrenia, schizotypal disorder. This is from ICD-10. Persistent delusional disorder, acute and transient psychotic disorder, and schizoaffective disorder. So what is schizophrenia? Is a psychiatric disorder characterized. So we can see is a psychotic disorder characterized by constellation of abnormality of thinking, emotion, and behavior. So there are three things that we can see. Not all the patients will present with all these symptoms. Sometimes we only see emotional symptoms where they present with a depressive symptom, okay? But from further history, we can see that there's actually underlying psychotic symptom. Sometimes we can only see the psychotic symptom after we treat the depressive symptom itself. Sometimes they come with a lot of behavior symptom, disorganized behavior, disorganized speech, and they can have distorted thinking. There is no single symptom that pathognomonic. It's very, sometimes it can be very abstract. So we have to really spend quite long hours sometimes to really pick up the symptom from the patient, because it's not easy for a person to really come forward and tell that they actually experiencing this psychotic symptom. And most of them, because of the social media and a lot of information actually available, so they already went through what's wrong with them. So they already know, sometimes they already know partly what actually they're going through, and then they can hide the symptom also. It's not purposely, but it's very hard to really admit. And schizophrenia typically is chronic, so it'll be sometimes it really can be lifelong. It depends how fast we start the treatment, how vigorously we can treat them, and then how we are actually monitoring the patient regularly. So this will actually predict the outcome of the patient. So with significant social, all these consequences can be better. So there are three phases of schizophrenia. Okay, we can see some patients. Okay, the prodromal phase is the initial phase where we mostly miss this phase of psychotic episode, where patient can appear isolated. Okay, they from going out, meeting friends, going for classes. If the students, if they are students, college students, from being able to go for classes every day, they might miss their classes, and then they prefer to be in their room, and then sometimes they will be more quiet. Okay, these symptoms sometimes look like anxiety symptoms, sometimes look like depressive symptom. So often mistaken by depression, anxiety. So these are the very important phase if we can pick up. Okay, that is prodromal phase. Sometimes this can last from 6 months to 1 year also. Okay, second is psychotic phase, where they can have perceptual disturbances, delusion. So what are the perceptual disturbances? They can have hallucination. Okay, hallucination. They perception. As no, is like our perceptual senses. Our senses actually, from what we see, what we hear, what we taste. So these are the perceptual disturbances. But here is false sensory perception without any stimulus from outside. So they hear voices when nobody in the room. So they hear these voices are talking to them, being very critical about their behavior. Sometimes these voices telling that they are bad, they are useless. Okay. Sometimes because of these voices also, they can have this mood symptom. They can be very sad, they can be crying because of these voices. And again, this can be mistaken as depression also. So whenever we see depressive patient, it's very important to really see whether there is underlying perceptual disturbances as well. In psychotic phase, they can also have delusion, which is thought disturbances. So they can have they can have this sense of being insecure. They cannot go into public places. They feel like someone is following. They feel like they've been spied by someone. They can't look at people. They always feel like everyone is actually talking about them. So these are the delusions, type of delusions they can have, and we need to really explore further to see, to confirm whether this is really subtle disturbances or delusion. That's why sometimes it's good for us to really talk to them more casually, so that they will know that so that we as a clinician, we can pick up this symptom. For the patient, sometimes they feel like we are just talking casually, but in our mind, we want to pick up these symptoms. And next will be residual symptom. Once we start the treatment, some of the patients still, they can have this residual psychotic symptom, such as this auditory hallucination. They can still have delusion. They can still be withdrawn socially. So these are the residual symptoms that can always present. But if we treat them properly, very fast, sometimes they can really function very well, even with these residual symptoms. So residual symptom is not obstacle for them to move forward and then for them to do their daily functioning. If we can really motivate these patients, they can really function with this, even with these residual symptoms. Okay, so these are the symptoms of schizophrenia. Just now I explained. So there are positive symptom, negative symptom, and cognitive symptom. So positive symptom that I mentioned just now: hallucination, delusion, and thought disorders. Okay, so these are the, whenever patient present with this, they really come forward and explain about this. Most of the time we will know that, okay, this is psychosis, this is psychotic symptom, whether this is schizophrenia or schizoaffective, what type of psychosis, then we can decide on that. But then most of the time, they won't come forward and tell, I'm actually hearing these voices, because for them, whether first they would have told this to their family members. They would have shared this with their family members. I'm actually seeing things when I'm sleeping. I'm seeing things in the room when I'm sitting. I'm hearing these voices keep disturbing. They would have shared this with their family members or close friends. And the first impression is nobody will trust if I tell. So they will come to us with the same perception. I don't think this doctor is also going to believe if I share this. So most of the time they will be very reluctant to actually share this. So it's our duty to really talk to them, to see if they are willing to share whatever they have, whatever symptom that they are experiencing at that moment. So giving them confidence to actually come forward and tell what actually they are going through. With that, right, most of the patient will, even though they will take time to really share, but most of them, they will share. They will trust. Once they develop that trust that I can share with this doctor, they actually understand what I'm going through, because this also comes with this judgment. So we need to really reduce this judgmental view of us. Whenever they come forward and share about this, really listen to them rather than judging them. Like what some of the family members that they cannot understand, it's not they purposely do, but they actually cannot understand, do that. And also delusion, sometimes they don't want to go out. Some of the patients, they close all the curtain in the house, they always close the door, they don't even talk to their neighbors. So these are the delusion that they can have. They believe that everyone like hate them, everyone against them. They believe that the neighbors trying to do something to them, the family members trying to do black magic. So when this become over and then really disturb their function, so then that's a problem. So negative symptom is sometimes frequently we can see, because if we can see, right, affective blunting, they won't have any expression, very lack of expression on the face. Anhedonia, apathy, all these can be quite similar to depressive symptom. So Sometimes we do encounter patients, actually the underlying diagnosis is schizophrenia, but then they are more easy for them to admit that I'm having depression. I'm actually very stressful, doctor. Okay, and then their presenting symptom can be, I don't have motivation at all to go and talk to anyone. I don't have motivation at all to go to work or go to college. So this can be their presenting symptom. And sometimes a sleep difficulty also can be presenting symptom. So even if their presenting symptom is very quite similar with the depression, we need to ask more further. We need to see how is their expression. I mean, we can see if like major depression or depressive patient, normally they will be very sad. Sometimes they can be very tearful. Is this patient also present like that, or they're just like telling the symptom? Sometimes in the difference between schizophrenia and depression, we can see from the patient expression. In depressed patient, they can be really sad, crying when they are actually in moderate to severe form of depression. So in schizophrenia, sometimes we won't really see that in their facial expression. So that can be, sometimes that can give a clue that it might be something else. So we need to explore more further. And cognitive symptom, impairment in attention. Okay, so this one we can see they won't be able to go to work. They will have longer time to complete their work. Sometimes they have a lot of notice from their workplace. So they have frequent MC because of this. So all these can be their presenting symptom in patients with psychosis generally. Okay, what are the differential diagnosis of negative symptom, like what I mentioned just now? So depression can be one of the differential diagnoses. We often see patients with schizophrenia diagnosed with depression and treated for years before we actually pick up, because they are well educated. Sometimes they are well educated. They don't want to admit that they actually have this symptom. And sometimes they don't know this is actually psychosis rather than depression, because the negative symptom look very similar as negative symptom of schizophrenia. So I had a female patient, about 35 years old, well educated master degree holder. She was treated as depression for 4 to 5 years before we actually revised the diagnosis. And all the while, there's very poor eye contact. So when I saw this patient, she had very poor eye contact, and then she kept telling, I'm depressed, I'm not recovering, despite they changed many type of antidepressant, 2 or 3 types of antidepressant, and optimized the dose. So so it doesn't click, this is like depression. So I thought ask more, and she kept telling that I changed few workplace because people, my bosses are always like very critical, they don't respect me. But then talking to the mother, mother said that never, no one actually commented badly about her, but she is the one thinking like this. So just click that maybe this is psychosis. So started her on antipsychotic. Within 2 months, she recovered really well, and then she could even go to work after that. So these are the things that we can pick up if we are very really notice their behavior, notice their symptom, and also giving them confidence. Actually, this is a safe place for them to really share the symptom. And effect of neuroleptic medications. Okay, sometimes in patients with Parkinson and with the medication, so they can also have psychotic symptoms. So we need to monitor if there is psychotic symptom that really is the thing. It's very good to refer them back to the neuro, that whoever that we are on with follow up with, so that they can adjust the medication. Or sometimes we as a psychiatrist, sometimes we add some antipsychotic to help them. Environmental understimulation. Okay, this sometimes we can mistake with this also. Okay, this happened a lot during the pandemic. So lack of social interaction produces lack of spontaneity. So lack of friends. So this is environmental factor. and the environmental understimulation. So sometimes we can mistake these with the negative symptoms. Okay? Physical illness, Alzheimer's disease. So not all the cases that we see actually schizophrenia, but maybe there is underlying cause. So that's what we want to pick up. And substance misuse, quite commonly we can see also. So what are the investigations? Normally we will do routine investigation. Normally we want to have a baseline investigation so that if anything happen after we start the medication, we want to have some baseline investigation. One, we want to pick up if there is any infection or any hyperglycemia, hypoglycemia, delirium. Okay, delirium can cause because of anemia, infection, anything serious infection in the body. Sometimes they can present with delirium where they can have psychotic symptom. Urinary, urine for drug screening. Okay, with the consent, definitely with the consent of the patient, if they agree. And normally we will do CT brain if young patient present with very acute onset of psychosis. Sometimes we want to rule out any other problem in the brain as well. And psychological, get very detailed history from the patient itself, and also collateral history is very important. Why collateral history is very important to get from the family members? Because what patient tell and then what the family members tell can be really different. Sometimes we only have time to see the patient, but whenever we see the family members, the history can be really different, and that can actually help us to really diagnose and confirm that this is actually psychotic symptom rather than simple stress problem. Okay, so, and what are the treatment mostly given for the patient is antipsychotic. Whenever we confirm there is a psychotic symptom, even though in prodromal phase, if we really confirm that this is actually schizophrenia, we start antipsychotic. We start with a low dose and then monitor the side effect, and then we optimize the medication so that they can have optimized treatment, and also they can, our intention is for the remission of symptom, definitely for the remission of symptom, and also for the full recovery of the patient so that they can go back to their own function. So schizophrenia is not actually, it doesn't stop them from being and achieving what they want to do, because as what I've seen, even many students after COVID, actually, I had a lot of adolescent and also young adult with full-blown psychotic symptoms. So our aim is to attain full remission and then for them to go back, because when they are just 21, it's a long way for them to go. So if we can really support them from the beginning, they can really do very well, even though if they cannot study in the studies that they have chosen. Okay, sometimes the studies that they have chosen can be very stressful. So we can give suggestion to choose other option or support them to go to the same studies if really they can do that. Okay, so what are the antipsychotic medications that we can normally we use? First generation. Okay, these are the example of first generation antipsychotic. Haloperidol is the most commonly, I think, many of us quite familiar with haloperidol, chlorpromazine as well. But nowadays we less use first generation antipsychotic, typical antipsychotic, because of the side effect itself. Because of the extrapyramidal side effect, so we less use typical antipsychotic, but there are people use because want to have a bit more strong action because it's a strong D2 antagonist. So next will be atypical antipsychotic. This is commonly we use now, such as olanzapine, risperidone, quetiapine, and clozapine. Here, why atypical antipsychotic is more better, even though there is metabolic consequences, metabolic side effect, but then it's more better for the mood. It also helps them with their emotions, okay, with their also with the cognitions as well. So, and with the negative symptoms. So it will be sometimes it's much better tolerated by the patient. And about the side effects, still some patient will have extrapyramidal side effect with this medication. Again, close monitoring can be very helpful. Another type is aripiprazole, also quite commonly we use. This is partial agonist of D2 and D3. So less side effect, and sometimes people who go to work, so they find this medication is much better. But when patient present with positive symptoms, sometimes this don't really work for the initial stage because it's partial D2. So we again go for atypical antipsychotic. Okay, so what we can do after we start the medication, definitely monitoring of the side effect, because most of the non-compliance issue is because of the side effect. So we closely monitor the side effects so that we want to encourage the patient to continue with the medication to get much better symptom relief with the medication. So we also one is extrapyramidal side effect, whether they have like tremor. Sometimes they can have tremor, drooling of saliva, stiffness of the hand, body. So all this can be the extrapyramidal side effect. Metabolic syndrome, okay, sometimes they can have derangement in their blood. Hyperprolactinemia can be one of the side effects of antipsychotic. So most of the time, female patient, they can have amenorrhea. And if this present, sometimes we send for serum prolactin to see whether it's actually raised after starting the medication, sedation, hypertension. So all this we can monitor very closely. So normally we start very low, and then we taper the medication slowly, and we optimize the medication. We make sure that we optimize the medication so that we can see the better result of the patient. Depot injection, I think some of us, after we start the depot injection, especially for patients don't want to take any oral medication, they're willing to go for depot injection, monthly injection. Sometimes we also send to GP clinic for the injection. So this can be one of the options to treat them. And psychological management, definitely psychoeducation, tell them what is the effect of medication, and then how this can be helpful for long term. Can be very challenging really explaining to them, but really good support and good explanation about the illness and the medications can be really helpful for the patient to continue the medication, especially young patients. And these are the things we do in the hospital. Okay, we refer to social worker if they have any difficulty. Okay, some patients with schizophrenia for long term, for 2 years and above, we refer them to social workers. Sometimes they can get their OKU card. So when they go for their regular follow up in the hospital, it'll be free, and then they can also get benefit for the OKU. Okay, so if they're working, also they can have some support from the social worker, their financial difficulty. And occupational therapies, if they have very severe cognitive impairment because of the illness, so OT, occupational therapy, can be very helpful. Okay, all this social skill training, all these are done actually we do this in the hospital, so we can refer them to the hospital for them to get rehabilitation from them. Okay, factors which are associated with poor prognosis, incidence onset, very young age of onset, long duration of untreated psychosis. So that's why we really want to pick up these symptoms early and then start treatment early and then really monitor them regularly so that they comply to the medication. And we can see very good improvement if they really comply to this medication. So our aim is like long-term outcome. So that's why we want to take care of the patient and monitor them very closely, see if they are if they have any problem with the medication, or we can switch the medication. Work closely with the family members, especially for young patients, because sometimes the family won't really understand what actually the patient's going through. Sometimes when they have lack of motivation, so that can be part of the illness, but the family will be thinking that, oh, they are very lazy. He's very lazy. He doesn't really listen. So even we shout also, they don't listen. So these are the words that can really hurt them even more. So explaining to the family members sometimes can be very helpful and support the patient. And history of obstetric complications and low IQ also can be part of poor prognosis. So now I'll just share a case, few cases. It's a real case, but I changed so that it can it can give a picture. Sometimes maybe some of us here also had this experience seeing this type of patient. So maybe it can give an idea how to manage this patient next time we see these patients. Okay, first case is a 30-year-old gentleman presented with history of poor sleep for 6 months. This can be sometimes very common presentation for patients with psychosis and lack of motivation. He could not focus at work and was taking frequent MC. So he was going to multiple GP to take MC because his frequent complaint is headache and poor sleep, and then cannot focus. So the next day, because of the poor sleep, having very low energy, to want to go to work. So he claimed everyone, including the boss, against him. So this can be very common problem actually. But then for them, this can be a serious but sometimes this can be part of the delusion that they have. Okay, so asking more further history on this can be helpful. He also mentioned that the boss is spying on him and he avoid going out in order to protect him. So so this type of patient, I have seen a lot actually. So these can be the main complaint. So sometimes when they say that poor sleep, rather than taking it, this is like simple primary insomnia. So we can ask even more further question, actually what's happening, or what happened until he cannot sleep for 6 months, it's so long. Okay, and then is there any experience that disturb him? Okay, yeah, like in depression, sometimes they will share that they keep thinking about a lot of problems, and then they'll be very tearful. But in psychosis, sometimes they will share this symptom because for this patient, from further questioning, he mentioned that he has been hearing these voices for more than a year, that worsening for 6 months, that he cannot sleep at all. Okay, so this was from further questioning. After some time only he shared this. So then, and then the delusion itself, everyone against him in his workplace. So apparently the sister also worked in the same place that he was working. So I was able to talk to the sister. The sister mentioned that everyone is actually very supportive for whatever that he's going through. We think that maybe he's stressful because the sister is the one actually brought him many times to GP, and then at last, from one of the suggestions, they brought to see me. So from the sister's point of view, everyone is actually very supportive at the workplace. So this actually give a clue. Maybe he is really believing that everyone is actually against him. So with the voices, with this delusion, started him on antipsychotic, he improved very well, and then could go back to work, and then could continue. The problem again, non-compliance after they become well. So the next question is, when can I stop the medication? So we have to really counsel them. Despite counseling, sometimes they still stop and then come back. So there's another challenge that sometimes we have to encounter as a clinician when we see this type of patient. Next patient is a 23 years old college student. Had many college students after the pandemic, because from going out and meeting friends, they actually shut down at home. So this when this student went back to college after the COVID, okay, the college informed parents, and parents were unaware he was absent from the college for 2 months actually. So just went back to college and then was absent for 2 months. So when the student was at home because of the pandemic, parents didn't notice anything because always in the room with the computer. So they thought that the student is actually doing her work, just like busy with the studies. That's why she doesn't want to come out from the room. But then when started going to college, she cannot really meet the college, her friends, and then college informed the family. So when the family decided to visit her, visit this patient in the hostel, they saw that the room was in mess. Okay, there was so much of leftover food where the patient actually ordered Grab food, because at the time Grab food is quite easy, because after the pandemic everyone like ordered Grab food. So keep ordering Grab food and then eating just very little, and then it's a lot of leftover. It was smelly, and then the clothes were not washed, so really bad. The parents didn't notice because the student actually coming back home. So every week the student come back home, but then just in the room. So they thought maybe busy studying. But then when they saw the room, it's really bad. And then only they realized that something really wrong. So they thought it's like the child, the patient was depressed. They brought for attention. Then from further history, noted that the patient shut down all the communication with the friends, all the Facebook has been shut down, everything was shut down, and then there's no communication, nobody knows actually what the patient was going through. And then we started on treatment. Took very long actually, took about 6 months, almost a year to really see improvement, that confident to talk again, confident to talk to the family members. So after that, it's like change from being in the room, coming out from the room, talking to the family members. It's really total change of the person. So even the parents told that I've never seen my child like this. It has been very long since I've seen really sit and talk to my child like this. So these are the improvement that we can see when we start the treatment. I think that is second case. Thank you so much. So I will go for any question if there's available.
Yes, doctor. Thank you very much. Okay, so now we actually go into Q&A session. All right, so there's already a question before even we start the talk today. Okay, this is from Dr. Michael. Can we admit a patient who is under a prodromal phase of psychosis in view of poor social and also family support into the psychiatric ward? And what is your opinion?
Okay, so yeah, if we confirm that, because it's normally we want to make sure whether this is really prodromal symptoms of schizophrenia or not. If we really confirm, and then if really confirm, okay, it's good for us. We can refer them to the psychiatric clinic first. Let the psychiatric doctor see, and then because in KKM, in our KKM facility, we are not only have admission facility, okay, we also have home visit facility. Okay, with the help of the psychiatrist that's seeing this patient or the medical officer in psychiatric department, we can monitor this patient first, really start the treatment, confirm this is schizophrenia, and then start the treatment. If really necessary, that means it's very hard to really monitor this patient at home. We confirm that this patient having symptoms of schizophrenia, and then there's a very poor compliance. If we even start the medication at home, then we can admit this patient for stabilization, initial stabilization of the patient. And we can also refer to community psychiatric care with the help, with the suggestion from the medical officer or psychiatrist from the KKM side.
Okay. As for primary care doctors, how can we actually, how the doctor can actually communicate with someone experiencing psychosis?
Okay,
is it a skill to say?
Yeah. So Yeah, because some of the patient can be very challenging. I need to say that can be very challenging, and sometimes we can really miss. But if because as primary care physician, they really experience because they're seeing so many patients every day, and they know when they are really sad, stressed. Actually, they are the first one to pick up all these things. So if they find like the patient keep telling stress, depressed, but then can't really see anything in the on the face right, they don't seem to feel like that sad effect. So they need to think that is there something else that actually troubling this patient. So sometimes it can be very helpful asking collateral history from the family members, talk to the family members, see how is the behavior of the patient at home, like frequently get into arguments for unnecessary reasons. Sometimes this can be part of the delusion. So this in this way they can pick up actually, and giving them confidence actually. Sometimes we have to tell them that we are here to help. Please, if anything really bothering, let them know, because some of the patients can be really regular patients for the primary care physician. So they sometimes willing to tell if we give them the trust.
Is it that in your clinical experience, right, psychosis affecting, as what you said earlier just now, that because of the pandemic, right, you're actually seeing more teenagers, and are they mostly come from, if they are coming from a poor family, right? So usually the parents would not be able to understand also what is psychosis and what is the symptoms and what they can do. So normally, how do you advise the parents, especially when they're coming from a probably illiterate, a poor background, how do you actually make them understand is that your child is having this, they're going through this kind of phase, So as a psychiatrist, what do you normally advise to those parents?
Yeah, thank you. Thank you. This is wonderful question actually. It's yeah, again, can be very difficult because looking at the parents, right, they are so worried. They are not worried about the diagnosis, they're worried about the future of the child actually. And we will sometimes, we won't tell the first thing itself. In the first, even though we know this is schizophrenia, but normally, if the parents are not ready, we see the parents are emotionally really down. Even the patient is having very difficulty to really accept the diagnosis itself. We will delay telling the diagnosis. We will tell that let us start on this medication first, and then slowly we will after some time we will explain about the diagnosis and what is the outcome, how is the monitoring going to be after that. We will definitely explain, but slowly being very sensitive to how they feel at that moment first. Then only we will reveal the diagnosis to them.
I see. Is it the psychosis is actually a genetic triggered?
Yes, it can be. Yeah, most of the time it's also because of the genetic contribution, and sometimes we don't know what is the reason. Some of the children, some of the patient, there's no underlying family history at all, and even if we ask uncle, auntie, they don't have also, but then they present. So it definitely can be genetic contribution, but then it can also sometimes there's no reason underlying.
Do you think because of how we grow our children nowadays are more protective and make them more vulnerable to end up, having these issues?
Okay, it cannot be a cause, but then it can be additional stress that can lead to, because when we see the etiology, right, there are some factors that actually make this person more vulnerable to develop this. And then what is the precipitating itself? Okay, if a child is already vulnerable to develop psychosis, when the stress is even more from the parents, from the school, from the public, all this, they can actually easily develop the psychotic symptom.
Doctor, is there any specific question that we can actually ask to the patients that especially those who very clever or masked on, they want to tell you the real thing, what sort of specific, maybe give us a tips that what sort of specific question that as primary care doctors can actually ask, and then to form a probably initial diagnosis.
Okay, it definitely depends on with what symptom they actually present. Okay, so in case patient coming for frequent MC because problem in the workplace, okay, maybe they already on antidepressant or maybe on some medication, but no improvement at all. So maybe sometimes they can ask, is there any problem in the workplace? So, but we don't confine to the workplace only. We broaden it. Is there anywhere else also you find like this? When you go out, do you find like people keep watching you? Do you find like, so these are the questions will actually give us more idea how this patient, sometimes their reaction when they tell this, they really feel scared. Okay, this patient that she's a mother of one child, she scared to go out. She is the one sent the child to school every day. For 1 year, she couldn't go out. So the husband thought she just don't want to go out. So a lot of arguments with the husband. But then when she came and saw me, she told that I already told this. Actually, I'm scared to go out. But the husband kept telling that nothing. Why you want to feel scared? But then she said, I feel scared. I can't even like see. I think people actually watching me. So giving a trust. Okay. Asking more on this now. Okay, but not really asking like we are actually looking for a diagnosis, but just friendly way of talking. Sometimes they don't know actually we are actually assessing the symptom, but our intention is here to help, and we know that something is not right. So we asking a bit more further in very friendly way. That can be very helpful for us to pick up these symptoms.
Okay. All right. So there's a question from the floor. Good afternoon, doctor. I was in the psychiatric department quite some time and planning to see psychotic patients in GPs. Is it possible to attend manageable psychotic patient at GP settings?
Okay, actually, for the starting diagnosis, I think still need to refer to psychiatrists. But I think follow up once diagnosed and then they're on proper medication, because certain things they still have to really certified by the psychiatrist to start the medication. And then I think follow up, we still for me, I still send to nearest GP sometimes for them to monitor, especially patients on injection, so they can go to GP for the follow up and really monitor. And then but my suggestion would be lies with the psychiatrist that treating the patient also, because if anything wrong, because certain things we still cannot pick up with the patient, especially the side effect or maybe very acute event, anything happen with the patient. So it's good to liaise with the psychiatrist if they can possible, even though they are confident. I mean, definitely most of them actually confident because they already been in psychiatric department. So actually they can diagnose and manage, but still they need to get a psychiatric assessment before they actually start the medication.
All right. I think there's no more question already, doctor.
Okay.
Right. You want to say a few words before we end the session today?
Yes. Once again, thank you for this opportunity. Hopefully, I'm not sure how much I should give because it's really vast talking about psychosis. There's so many conditions that we can talk on psychosis, but I think this is a good platform for primary care physician to really see what are the things that they can pick up when any patients come and see them, because most of the time patients are more comfortable to go and see GP first. So, so what are the conditions that if the patient coming frequently in a week, in a month, frequently coming and seeing them for same problem, so they need to see whether something wrong or not. Is there anything more that they need to look up rather than treating the same thing again and again, or getting some advice or a suggestion from any psychiatrist so that they can see whether this patient need other referral or not. One, and then if any patient's already on antipsychotic, and then please encourage them to continue that medication, because the compliance itself can really ensure a good outcome, for long-term outcome. Because for us, we don't want them to just sit at home because of this illness. For us now is our era is actually towards them function as normal person, be in the community as a normal person. That's why we have community psychiatric care. We don't want to keep all the patients in the hospital. We want them to be in the community among the people that they used to be, rather than being in the hospital. And we encourage them to work. The work that they can do, there's so much of work that they can do. So this is actually our aim. So if any patient come to you all, encourage them, and then talk to them, talk to the family members, give them support that even though this is an illness, they can still support, they can still go on achieving whatever goal that they want to achieve. This is what I used to tell the students. Actually, with this, the students want to continue the medication, because they know when they don't taking the medication, they can't really function, they can't really focus, they can't study. But then when they on the medication, they can study, they can achieve what they want to do, even though they took some time, some break. But then after that, they can achieve. Some students, they achieve more. Some students actually, they score all A after the medication compared to before medication. So even better result. So we want to see this. So we are going to this type of error. So I really hope like working together. So definitely it's very hard to manage psychotic patient alone, like a psychiatrist also. It's actually the multidisciplinary team management. We also work closely with the parents, and also if also primary care physicians, they are involved. So we are also good to also work with them for better outcome. Okay, this is my humble request. With that, thank you so much.
Thank you, Doctor. So, okay, we were going to end the session today already. Thanks for joining us once again. So we're going to have another session we're going to have this monthly session. So stay tuned with us. We're going to see you in November. All right. Thank you, Doctor. Thank you.
Thank you so much. Yeah.